first long-term care education webinar of 2024. I'm very excited to be here with our guest speaker, who I will introduce in just a few moments. Before I officially do that, I want to just take a moment to recognize the fact that Concerned Friends work takes place in the traditional Indigenous territories of what is now called Ontario, covering 46 treaties and other agreements. And I am coming to you tonight from Treaty 13, Dish with One Spoon territory, also known as Toronto, for those who want to pronounce it like the locals. The traditional territory of the Anishinaabe, including the Mississaugas of the Credit, the Haudenosaunee Confederacy, and the Huron-Wendat. And I recognize that this land today is home to many Indigenous, Métis, and Inuit peoples. I'm grateful to be hosted here
Sorry,
and have the
can't hear
opportunity
anything.
to advance our mission of care and equity and dignity for all seniors residing in long-term care. So I'm going to cover a few housekeeping items, if that's okay. So one of those things is just to be sure that we're all on mute while we roll out this wonderful presentation tonight. There will be a discussion portion that will happen toward the end of the event or of the session tonight. We are recording, as you probably noted. So that does mean that the recording will be available post-session. And in addition to that, if you need it, you are welcome to enable closed captions just in the it looks a little different on everybody's screen, but it usually is in the More menu, and it's just under captions. If there are any questions, comments, ideas that come to mind while we are getting started or while our guest speaker is presenting, I'm welcoming you to put those into the chat. That's where I'm going to pull them from and help moderate the discussion tonight. So before we officially dive into the topic, models of care in Ontario long-term care homes, I thought I would do a little bit of stage setting and talk a little bit about the organization, our organization, and even sort of the impetus for this webinar series. So Concerned Friends, we're a volunteer-run charitable organization on a mission to improve the lives of Ontarians living in, working in, and involved in long-term care. We've actually been around for a while. So for those of you who might be new to us, maybe you found out about us through another organization within the sector or community partner. We welcome you and we're excited to have you here. And maybe I can just share a few highlights of some of the impact that we've created over the now 42 plus years that we've been around. So we have a bit of a legacy, gratefully, even though we are a small and mighty organization, grassroots volunteer run organization. But one of the things that I can sort of share with you is that we, starting way back in the 80s, we advocated for the implementation of the framework that is now the residence councils. We championed the Residence Bill of Rights that was implemented in 1987. We issued the first report card on the Ontario long-term care home sector in 1991 that contributed to the mandatory public posting of inspection reports in homes to ensure accountability. And by the way, that's not a uniform occurrence across the country. That's actually a fairly unique thing for us here in Ontario. We launched the Family Council pilot project back in 1998, which then in 2004 became sustainably funded by the Ontario Ministry of Health and Long-Term Care. We've helped hundreds of Ontario seniors and their families navigate the long-term care system, find information and resources, address their issues, complaints, and needs. We spotlit critical issues during the COVID-19 pandemic, which, as we know, has ravaged pretty much every sector, but none more than our most vulnerable, that is residents in long-term care homes. And we launched a long-term care awareness day back in November 2022, which we now hold every year. So that's a little bit about us. We are a charitable organization. All of our resources, programs, webinars are offered free of charge. And we, of course, welcome donations and new members all the time. We do not have any other sources of funding. So in order for us to be able to continue to do great things like we have done and bring webinars to you, we appreciate your support. Now, the reason we wanted to do this webinar series, in addition to the fact that it is part of our mandate as an organization to provide awareness and education to Ontarians, we acknowledge the fact that the long-term care system is needlessly complex and confusing. It seems to change all the time, weekly, monthly, there's new information coming out. And it can sometimes be either not specific enough or too specific and not applicable for the people who are looking for information. This webinar series we thought would be a great opportunity to identify some of those informational needs, to invite you all to engage with us in conversation, and to gather input from you about the other topics that you might want to learn more about. So to that end, at the end of the session, once you close out, you'll be prompted with a survey, and we would invite you to provide us with any feedback and input that you think would be helpful for the future of this series. And hopefully you'll come back again. So without further ado, I'm very pleased to introduce our guest speaker, Aria Wills. Aria Wills is a health services research coordinator, currently supporting research and end-of-life and palliative care with the Isenberg Lab at the Bruyere Research Institute. Her research interests have focused on improving the quality of life and care for marginalized populations across care settings. Her passion for advocacy and reforming long-term care emerged when supporting research on the impact of the COVID-19 pandemic on LTC homes and the opportunities it presented for examining our current model of care. Now, Aria joined Concerned Friends as a member and volunteer in 2020 to further lend her support to the cause, and she remains a valued member of our outreach committee. So I'm very pleased to pass the mic to Aria.
Thanks, Crystal. Thanks so much for having me. I'm very excited to be a part of the series and the first speaker. So I'm Aria. I wanted to give you a little bit more about my background before I get started, just to give you maybe a taste of what health services research means and can look like. So I've supported research and moved through a couple of positions focused, as Crystal mentioned, on care for individuals who tend not to be prioritized within the healthcare system or within research studies. And so my journey started as a clinical trial coordinator for geriatric oncology, a trial at Princess Margaret to try and improve the standard of care for older adults with cancer. From there, I moved on to support research that I'm going to be speaking about tonight. And that was in long-term care during the pandemic, which was a much needed time to take a look at it. And as Crystal mentioned as well, I'm now working as a research coordinator for palliative care research under Dr. Isenberg at the Bruyere Research Institute. And there we're looking at palliative care for individuals, again, who don't have cancer and so often don't have access to care. So that's a bit of a taste of what health services at that level can look like. I'm here today, of course, to speak to you about those long-term care home studies a little bit and give you some insight into particularly the idea of a collaborative model of care. And when I'm talking about providers, I mean specifically between physicians and nurse practitioners in the long-term care home. I'm hoping that I can give you a bit of insight into where we've come from and a look towards the future of what that model might be. And the three questions I'm hoping to answer, although they won't all be packaged up perfectly with a bow, but I want to talk about first what the model of care has looked like in Ontario for primary care providers. Secondly, why we should consider a collaborative model of care. And thirdly, what, if we are going to consider that model, what does the optimal collaborative model of care look like? The work that I'm going to base this off of is work that I've supported as a research staff And I'm going to anchor the conversation tonight in those findings. We'll provide you links to the research articles. They're all open access, so you don't need any special login to access them. And they'll also be posted with the recording afterwards if you'd like to access them then. And this is the research of whom Dr. Kathy McJilton is the principal investigator, and of which I supported also as a co-author on all these studies. Many of our collaborators and co-authors are also stakeholders within the organizations that tend to be very involved in long-term care. So I wanted to start just by stating that the views that I put forth tonight are my own. They're informed by our work and what the team has done. However, they don't necessarily reflect the views of Dr. McJilton or my other co-authors. And I guess I want to say too, and preface the conversation by saying that I am aiming to be as representative as possible of the current understanding of this collaborative idea in the literature. However, I don't have the capacity or the time to do that in this little webinar. But what I can do and will do is lead you through the journey of the team that I've been a part of, their research, to one current understanding and what that might point to in the future. Practically, for decision makers and also for researchers and what we have yet to find out and need to know. So to start off, I thought I would just give a basic overview of those two roles in Ontario. The physicians that I'm sure if you've been involved with a long-term care home as a caregiver, a family member, with residents at all, there is a physician involved in their care. Long-term care homes have to have a medical director, and that role is filled by a physician. These are often family physicians, and there are other ways in which physicians are employed in the home. This might be as an attending physician or as a most responsible provider. So these are the clinical leaders in the home. All of these titles are the clinical leaders in the home who are most responsible for the resident care. Often they are employed by the long-term care homes, and often they work part-time in that, as I mentioned, family physicians have other practices that they might attend to. And so this doesn't comprise a full-time workload usually. In contrast to the physician role, there are two types of approaches that nurse practitioners can be deployed as in long-term care in Ontario. And so these are advanced practice nurses. They have a lot of authorization to do many things that a physician can do, not all, but they are able to prescribe and order tests and that sort of thing. And so they can be considered primary care providers. There are some nurse practitioners deployed to long-term care homes as attendings as well. And so these nurse practitioners tend to be employed and paid by the home. They tend to work full-time in about one or two homes, and they manage the overall healthcare of residents. But as I mentioned, there is always a medical director, so it's often in a sort of shared care model with the physician. What I will say with that up to this point is that it's not very clear what that shared care necessarily looks like or needs to look like, how those responsibilities parse out. And so I'm going to speak more to that later, but yeah, it's pretty undefined currently. The alternative is that some nurse practitioners are a part of what we call nurse-led outreach teams. And so these are nurse practitioners that are deployed from the hospital, and they work in the homes as more of an on-call staff. They can attend to up to 10 to 20 long-term care homes, and their role is actually to address acute or sudden onset of issues, healthcare issues and concerns. And the main goal here with this team is to reduce emergency room visits by bringing the care needed to the home. And that's just because we know that residents tend to do better when they stay in the home, even if that's a long-term care residence, rather than going to the hospital. So those are the two ways in which nurse practitioners can be deployed as well. And this is the status quo, I would say. And leading into the pandemic, that was the status quo. And I would venture that the reconsideration of this model began then with the COVID-19 pandemic, as it provided this unprecedented and kind of unexpected opportunity to examine the role of the nurse practitioner in the long-term care home. So, to provide some context as to what was changing and what I mean by that is, um, as I said, I began my work in the second wave of the pandemic with Dr. McJilton. And so I'm sure we can all recall how strange life had been from the first wave into the second wave in 2021. One instance of things changing big time were the roles of primary care providers. And so what had happened during the first wave was an emergency management act from the government had authorized nurse practitioners to act regularly as the most responsible provider, that role that I mentioned as the clinical leader in the home, as well as to work as the medical directors in long-term care homes, which is the role conventionally reserved for physicians. And this was because of a recommendation from the Physicians Association to limit in-person attendance for physicians and preferring virtual care for reasons we all remember, to prevent outbreaks, to lessen stress on our healthcare system and those pressures. So in the first paper I want to talk about, which was led by Dr. McJilton, it is called Nurse Practitioners Navigating the Consequences of the Directives, Policies, and Recommendations Related to the COVID-19 Pandemic in Long-Term Care Homes. In this study, the team interviewed nurse practitioners during the second wave of the pandemic across Ontario whose roles had been impacted by the change. Firstly, in no surprise, nurse practitioners had a great contribution throughout the pandemic in improving residents' quality of life and supporting staff. These are things we know they bring and strengths they have. But they also took on new responsibilities in that they contained the spread of the virus and were involved in the infection prevention and control in homes. They were available to staff who were very much burnt out at the time and needed support. And they also embraced new responsibilities in welcoming new residents to the homes. They were the ones who would set up, coordinate, and administrate vaccination clinics for new residents entering long-term care. And so with these interviews, another one of the highlighted changes came as in wave 2, physicians were then welcome to re-enter long-term care. So we saw as they did so to varying degrees, this impact on the role of nurse practitioners. The recommendation that changed all of this was from the government saying virtual care will continue as a regular part of physician practice, but it is now appropriate and probably safe in most circumstances with personal protective equipment like masks to return to in-person care. And so, interestingly, from the perspective of nurse practitioners, they perceived really enhanced collaborations as the physicians were welcomed to come back in person. And for some, this was a brand new relationship that they had had to form during the pandemic and now was lasting as they reintegrated. And for some, it was a strengthening of what their relationships looked like prior, but may not have had the opportunity to expand to without this change. Another interesting thing is that many nurse practitioners continued to be the primary care provider during the pandemic because physicians had come to rely on and understand their competence in providing that primary care in the physician's absence. And as a result, a lot of physicians, not all, increased their time back to long-term care, but not to pre-pandemic standards. And so there was a new balance amongst the responsibilities and who was providing care and relied upon. And nurse practitioners, again, from their perspective, felt challenged ongoing by the lack of recognition that can happen in these types of stressful situations, but also that at this point in time, their value as a provider in that sense was starting to be realized. So I think the key takeaway from this first study is that nurse practitioners and physicians in Ontario demonstrated the ability to work together, and they integrated into this novel collaborative model as the pandemic subsided, and nurse practitioners stayed working alongside physicians. I think that this study also points to the fact that nurse practitioners were properly positioned to help alleviate some of the burden and pressure that the healthcare system feels with, very few physicians, and a disproportionate amount of residents assigned to a small number of physicians, just based on distribution. The second study that I wanted to touch on, performed during the pandemic, was called the Nurse Practitioner-Led Implementation of Huddles for Staff in Long-Term Care Homes during the COVID-19 pandemic, also led by Dr. McJilton. And the team aimed with this study to develop an intervention to address some of the issues that the long-term care homes were experiencing during the pandemic. And some of those issues included a lack of communication, collaboration, some difficulties with teamwork, the things that fall by the wayside when you're in a pandemic. And so what the team introduced and developed were a huddle meeting. So these are 15-minute stand-up meetings that were introduced to support staff well-being during COVID-19. And part of the intervention was that it was led by a nurse practitioner. And in the literature, the nurse practitioner's strengths tend to be well established as a leader, so they were chosen as a change champion for this intervention. The outcomes tended to be good from these huddles. I can say that it helped staff, direct care staff, their moral distress went down, which means they were able to provide care that they felt morally was the correct care to provide, which is not always the case. And there can always sometimes be a clash between those values. And allied care and support staff perceived higher levels of support from the NP as well. So it was really beneficial all around. And this paper, the team posited that one possible reason for the good outcomes, we don't have a correlation to say this is so, but one possibility is that the nurse practitioner was involved. And the nurse practitioner, according to our interviews with all the participants, was able to address resident care issues that were important to staff and that they valued, but that they didn't have within their own capacity or scope to do themselves. The NP was able to encourage a collaborative approach to problem solving amongst the staff, and also was the person to discuss their well-being. So there were many strengths beyond the clinical that jumped out about the nurse practitioner role in this time. Expanding on this huddles intervention, we then looked further at some of the barriers and facilitators to implementing the huddles. And so what I mean is factors that helped or hindered make the huddles work at such a tumultuous time. And one thing that came up was another factor about the nurse practitioner role that seemed pretty important going forward. So the paper that I'm now referencing is called Assessing the Implementation of Nurse Practitioner-Led Huddles in Long-Term Care using what we call the Consolidated Framework for Implementation Research. That's all a fancy way to say that we used a methodology that's been established in the literature. We applied it to this implementation project and tried to figure out the barriers and facilitators. I led this study or this project and paper. And in assessing the implementation of the intervention, what we found was further evidence that the nurse practitioner role is beneficial, particularly with greater consistency in the long-term care home. So of the nurse practitioners involved in this study, one was on a contract basis with the home, providing a total of around 8 hours of care, 2 to 4 days a week. But notably, they were also involved as a full-time nurse practitioner for 2 months in the first wave of the pandemic. So they were relatively well integrated into the home. And in the second home, the nurse practitioner was an on-call type role through that nurse-led outreach team I mentioned earlier. And so she was, and they were both viewed, she was viewed much more episodically for more acute care. And so not necessarily related, but just as to give you the results, the nurse practitioner with the greater presence in the home, also they had a more full implementation of the huddles. And so it appeared that the differing amount of time that each nurse practitioner spent in the long-term care home affected their capacity to build rapport, have flexibility in the role, and show a consistent presence in the home that was valuable to make an intervention like this work. Also, interestingly, despite this one nurse practitioner's capacity to spend more time in the long-term care home, Both were ultimately characterized in the interviews with participants as more external contract staff. They were viewed as external. And it did appear then that perhaps nurse practitioners who are filling a full-time permanent role would be better optimized to actually make an intervention like this work and broaden their capacity for all these good things that we've been seeing for rapport building, flexibility. And these are all important ultimately because it leads to better quality of care for our residents. So that's the gist of the three papers that I've wanted to cover at the start here. And I'll just sum up what I hope are the important takeaways from those. Number one, nurse practitioners and physicians, they worked well together and they worked in a new context together in Ontario, emerging from the COVID-19 pandemic. That was new. Secondly, the nurse practitioner is a valuable member of an interprofessional team alongside the physician, who's also invaluable. And the nurse practitioner can provide strengths to a team that are beyond clinical. And finally, I wanted to wrap up this last study by saying that the nurse practitioner's role and their efficacy in that role as a change champion, as someone who is a leader of staff, it may be dependent on the amount of time spent in the long-term care home, and that factor may be crucial. And it also may be really important that they're working full-time. So while we hold those three takeaways in our minds, I also want to talk about the context that we now find ourselves in Ontario. So for those of you who aren't familiar, the government of Ontario has relatively recently provided funding for an additional 225 nurse practitioners. That's almost $60 million towards those professionals. They've also incentivized homes with funding for one salary of an attending nurse practitioner. And so we are more than likely going to see more attending nurse practitioners arising as we go forward. And if so, I think it's important to think about those takeaways that I had you put aside and consider the pressures on the healthcare system and this new funding. And it appears that a collaborative model in which the nurse practitioner is providing primary care alongside the physician will be really valuable going forward. The last paper I want to touch on is called Nurse Practitioner and Physician Collaborative Models of Care. And this is a scoping review protocol. And that means that this is the paper we published to tell you, that was led by Dr. McJilton, to tell you what we are going to research. It doesn't report on the results because those have not yet been published, but they are coming. What I can tell you are the questions that we're asking, the factors that the team will be looking at as important for these collaborative relationships. And I can provide you with some of my own takeaways. So the primary question I would say that this review of looking at all of the literature within the academic databases that we can, will look at what are the structures, processes, and outcomes of these collaborative models between nurse practitioners and physicians in long-term care homes, identifying those factors. So I'll break that down. The structures are factors that might influence collaboration. So this would be things like nurse practitioner characteristics. Are they a full-time nurse practitioner? Do they spend 8 hours in a home? Physician characteristics. Are they the medical director? Do they have a specialization in geriatrics or anything else relevant to long-term care? That would likely influence collaboration here. And we could also look at things like long-term care home size, who's funding the home. So these are important factors to consider. In terms of processes, these are components, or we can think of them as activities that would happen between the providers that comprise collaboration. So what does that interpersonal relationship look like? How does one describe in order to replicate a relationship of mutual trust and respect and of teamwork? That's what processes will be identifying. And in terms of outcomes, the team will be looking at whether residents outcomes and conditions, as well as systemic conditions, change because there's collaboration involved. How does it impact that? And does it improve care like we would assume it does? And by how much? Um, and we're looking to the literature for those answers. Uh, I can't tell you now that there will be one silver bullet of a model that will be optimal care and that you will see implemented in Ontario. I imagine that there won't be one size fits all. Maybe it will look like guidelines that can be applied flexibly. But as I said, all of that is yet to be determined in the academic literature. But it is important to think now about, with this additional funding, the best collaborative models. And for now, think about some considerations from 3 papers I mentioned going forward. And this is from my perspective. So the first thing I think that will be important in looking at the collaborative models of care will be standardizing practice and care amongst both providers. So we saw that in the pandemic, the nurse practitioner role became much more well understood. There was a lot more exposure to the role for other providers, for the homes. It allowed this opportunity to understand it and where it fits within the home, where it can fit. And so it may be that clarity around the role in each role will be important to support the integration of each moving forward. The second takeaway from my perspective is that each provider needs to be empowered to the full extent of their scope of practice. And what I mean by that is, as I mentioned in the Huddle study, nurse practitioners bring a lot to the table in terms of things beyond clinical care. They provide staff support. They encourage collaboration. They are mandated to educate as well in their roles, other staff, and expand capacity. And so both of these providers will end up being crucial parts of the interprofessional team. And further, maybe that empowerment to the full scope means that this movement towards attending nurse practitioners is the right way to go. The full-time model, it will be important to study it as it emerges, as we start seeing these nurse practitioners hired, but it does appear that they can be more effective the more they are in the home. And finally, and this is the most challenging one and the most abstract takeaway, is optimizing the dynamic and that interpersonal relationship between physicians and nurse practitioners. These are both extremely valuable roles, and as we've seen in the pandemic, and I hope I've been able to explain, is that they've been able to change and grow within new contexts, and that this idea of collaboration is feasible. It wasn't structured and it wasn't described, but it was able to flourish in a time when it was needed. Nurse practitioners embraced new responsibilities at the time, and the hierarchy of what normally would occur in a long-term care home was shifted for a period of time. And when physicians did return, nurse practitioners perceived themselves to be appreciated and understood surrounding their competence. So those are my 3 takeaways that I would say, looking forward, without that concrete scoping review to point you to yet, that are possible to glean from the literature and the research that I've shared today. And finally, I want to come back to those 3 questions that I brought up at the very beginning. So what has the model of care looked like in Ontario for primary care providers? Some shared care exists. It's not clearly defined. It wasn't prior to the pandemic necessarily. I think that the roles and responsibilities of the spread between each could be further clarified. And COVID-19 clearly opened up some possibilities. So that shared care can expand and hopefully be defined better. Why should we consider a collaborative model of care? Nurse practitioners and physicians both bring unique strengths and equally valuable strengths to an interdisciplinary team. And we now have this resource of funding for nurse practitioners that may really help alleviate some of the pressure on the healthcare system to have primary care providers, and to have staff supports and clinical supports that match all these new beds that we're hoping to have in the homes. And finally, what is the optimal model of care that is collaborative? Not yet clear, but we can look at the literature to point us to how we could make this happen and be feasible. I'm excited personally for the possibility of the future development by researchers for a tool that can be used across long-term care homes, some sort of laid out model, a toolkit, a resource outlining this that can be applied. And the part that I'm particularly looking forward to seeing what comes from it is in identifying the strengths of the how. How do providers interact? How do we encourage a sense of teamwork, of I learned from you and you learned from me? I think that's going to be tricky, but I am optimistic that as we see these roles introduced, that the research world will continue looking at that. Thank you so much. I'm now happy to take questions. And again, the references will be put in the chat. And also discussion, I'd love to hear from you and your perspectives about this, because we all have our own lived experience, I'm sure, with this particular primary care provider situation. So
Amazing. Thank you, Aria. I want to just say personally that we all, I think, could agree that COVID-19, the pandemic, what we all lived through in various ways offers a lot of lessons. And I'm just especially grateful that you and your team are really thinking through the opportunities and how we can sort of take those reflections, learn from them, um, do it differently, do it better, 100%. So thank you very much for that. And I learned a lot. I was taking a lot of notes, which I'm sure I'll also be able to reflect on later. But I'm noting that we do have some questions, so I would like to be able to get to those. I have some that I can just kind of pull right out here. So one question from Julius is, do you still see the need for more research on these collaborative models?
yeah, I mean, I think that that probably came before my last point here, looking at the timestamp. So I might have answered it, but I'm happy to elaborate on that even more. I think that it will be tough. I think that we would know already if there was one fantastic model of collaborative care out there. There are examples of ways that it works in the US, for instance. There's something called Evercare. And so it is somewhat collaborative, but in the papers that I've seen on Evercare, it doesn't describe that process part, um, how to integrate those roles in an interpersonal dynamic, how to define role responsibilities. Is it an individual situation to each home and each dyad of providers, or is it something that we can make a blanket statement about? That's something. So those are the pieces I think that I would be great to know more about in the research, and that I'm not sure are out there.
Okay, fair, fair. So Anne asks, do you feel that the time it takes for the huddle, which I think you had said it was maybe 15 minutes or maybe it is 30, does that potentially interrupt resident care?
Oh, great question. I'm glad someone's asking about that paper as well. That's very fun. It was a big consideration in that study, 100%. It was during the pandemic when it was chronically understaffed as it was. It was something we heard from many direct care providers in the interviews, I would say. Um, there were ways of which the scheduling worked, and that the team tried to accommodate doing that. And one of those ways would be, for instance, on changeover and takeover on shifts. So in the very first few minutes before they step onto the floor, or the few afterwards, um, could they make it happen then? And was it valuable if it happened then, or did staff want to leave? Um, was the nurse practitioner available at that time? So I think that going forward, that would be a really important consideration. Uh, there is a toolkit that the team developed that is now available to long-term care homes to implement that intervention if they were interested. It's a huddle toolkit, nurse-led, nurse practitioner-led. I can also provide that resource, but a part of it is there is flexibility in it. So it would, if there was a bell going off and a provider needed to go and attend to a resident, that was 100% the priority. This was really just to try and ameliorate some of that burnout and some of that not feeling heard. And this was the intervention the team developed to try and address that. Um, yeah.
Yeah, that's great. And I think that would be amazing if at some point as part of our follow-up, we could share the whatever information you have on the toolkit. I think that would be very interesting for those who are in attendance and for those who are watching the recording. So I have another question here. Do you see any potential conflict between the role of the nurse practitioner in a full-time context and that of the director of care in a home, considering that both are registered nurses?
Mhm. Yeah, that's an excellent question. I think that introducing a new role would potentially have an interaction with a lot of different providers in the home. Um, it also, you know, conflicts or overlaps in departments with the physicians. So there would certainly be a level of integration needed across the home. The director of care, from my understanding, is a little bit more focused on management of direct care staff. And so the nurse practitioner really would, in this context that I've described, I believe, be more of a clinical leader, um, and help with improving clinical capacity of staff. We, for instance, with the huddle intervention, I imagine that a director of care who's really in touch with their staff would also be a great change champion for that, from my perspective. So that it comes back to me to that interpersonal relationship and how complex those can be between providers, and it will be like that for many different roles interacting with a new situation. So yeah, I'm not sure how to address that personally.
No, and I appreciate that, and I appreciate that you're sort of using your own lens and what your the context and frame of reference that you have. So it's interesting for us to get that insight. So I have a few more coming in from through the chat here. So one question is the current increase in nurse practitioner roles in long-term care preceding a reduction in the requirement for medical doctors, similar to the push for no longer requiring nurses to dispense medications?
Hmm. I can't say that I know. I don't think they've said anything about that. And so it would be interesting to see if that is the case. Uh, there, there are a limited amount of providers as there is. We know about the staffing and the resource shortages, so it'll be interesting to see. I can't predict that one. Um, yeah, but now with the additional funding, at least there is some supplementary support in these homes.
Hmm. Hmm. Yeah, so it remains to be seen if it is a trend that will emerge. How do you see the role of the nurse practitioner in leading change toward implementing person-centered care?
Hmm. And I think it's part of and I don't want to speak out of turn. So the Nurse Practitioner Association of Ontario has great resources on what the role of a nurse practitioner really is, and they, along with their clinical practice, tend to promote or are meant to promote health and prevention of illness and injury. They do all the assessment and diagnosis. So there's that aspect. And as I mentioned, there's also the nursing aspect that they bring from their background. Um, I think that by having more primary care providers in general, that would point to more person-centered care, just ensuring that those hours are available and met, and that the most responsible provider has the capacity to take the time to ensure that person-centered care. I think that would be one way. But as I said, the nurse practitioner has been studied a lot. The role has been studied a lot, and they are really excellent leaders in this sort of context for implementation. So if there's many person-centered interventions and ways to go about that, and so I do think that they'd be a great candidate to be the one of the leaders.
Great. Yeah, interesting. So there's a comment here. I would suggest that a psychologist be brought in to assist when a nurse practitioner is being introduced into a long-term care home. And I think we certainly all acknowledge the interdisciplinary needs that exist in a very unique setting like long-term care. Do you have any thoughts on that in particular?
I'm interpreting this as the psychologist would be for staff and to organize staff dynamics. So I can imagine that would be helpful. I think most organizations could use something like that to guide their leadership. Um, yeah, I don't know. And it would be interesting once, as I said, the research comes forward towards a more solid understanding of this model that um, maybe that's an additional professional is involved in that and the implementation of it. Yeah.
Mhm. So a couple more questions here. You mentioned that under the new funding, there'll be salary provided for one nursing practitioner per what? Is it per all long-term care facilities, or can you maybe explain a bit more?
Yeah, definitely. So it is funding for any long-term care homes that opt into this uh, uh, initiative. They will provide, I can't remember the exact number, but it's roughly the salary of a nurse practitioner to the home to take on an attending nurse practitioner in the facility.
Okay, great. Um, so do you think that there'll be any overlap between nurse practitioners and personal support workers?
Oh, interesting.
Hmm.
So, um, personal support workers are hugely important. The long-term care homes wouldn't run without any one of these interprofessional team members. Um, I don't see that the roles would conflict in that one is a registered clinical role with a leadership component, and the other is a direct care role. And what I do think is that by having someone, a primary care provider in the home more frequently than, say, a medical director is capable of and has the capacity to be, um, or than an on-call nurse practitioner, that that type of engagement with staff could be beneficial and um, would certainly improve the quality of care. That trickles all the way down. So I think it would be beneficial if anything.
Hmm. Yeah, of course. Well, we'd like to think that all of these different critical roles can collaborate and work together because I think we probably all believe that there's an underlying benefit to the resident, which is mostly why we're here. So I think that's fair. I have one other comment here. They would obviously be remiss not to use it, but would you know if the new funding is mandatory to be used? So I think you'd said that it was an opt-in. And if so, by when? Are there any guidelines around that as far as?
And I can share the government page. It's the Government of Ontario has put out this funding. Let me just think here for 2 seconds. Um, da-da-da. And so I will share this with you, Crystal, this page afterwards, but it is funding that is prorated for the first year that the home participates. I don't necessarily think that it's limited, but again, I can share this, and um, it's a government page, so I probably understand it about as well as anyone else on this call.
Yeah, no, that's fair. And I appreciate that because, if you can help consolidate some of this for us, then we can certainly distribute it and get it out to folks. So I think we're gonna probably take just this one last question here, and then we'll have to sort of shift gears to wrap up because I'm just mindful of time and want to respect that everybody has joined us up for up until 8. Do you have any thoughts on social work positions being added, in addition to the nurse practitioner positions within this new framework?
I haven't considered social work necessarily in this idea of the collaborative model, and I'm not sure that the team is focused on that role, but I think that social workers are also one of those um, super valuable resources and under available resources across care settings, frankly, right now. And so I don't think that they will be added as a must under the new regulations. The funding is pretty clear for nurse practitioners, but they do offer, in a similar way, a lot of those um, interpersonal and person-centered care focuses that are really important. So I think they're a really valuable role. There's a lot of this that just has to do with there needs to be more funding, and um, yeah, the more staffing, the better.
Yeah, agreed. And I mean, Concerned Friends has really long been sort of advocating for um, you know, allied health professionals, social work, really any of the critical disciplines that need to be engaged in care because um, we're human beings, we're complex people, we have varying needs, and they continue to change and dramatically sort of emerge differently. So thank you for that insight. Thank you, Aria, so much for sharing your research and or your team's research, and for sharing all of these wonderful resources and ideas. I think again, what this reinforces for me is how much opportunity there is to kind of revolutionize the system, and how these conversations can support us in advocating for different frameworks, for collaborative models, for things that we haven't necessarily done before, things that we've tried and that have emerged because of a need. So sometimes we just need to recognize that and not do things the way they've always been done because that no longer works. So thank you so much for sharing your time with us tonight. I want to thank everybody who attended. I want to, of course, extend special thanks to the Concerned Friends team and everyone who helped put this wonderful webinar together. I'm going to just pop a couple of links in the chat here because I hope that we can do more of these. I hope that all of you will come back to attend more of these webinars, and we would love to have you join us as members and supporters and to continue the work that we're doing. Don't forget, there is a survey that will pop up once you exit, so please provide us with some feedback. We'd appreciate it. Let us know what other topics you would be interested in learning about. We're game to do more of this, and we thank you so much for attending tonight. Thank you again.
Thanks, Crystal.